Yeah, we'll start, and you look to this image of the barium study by of the small bowel and large bowel, and you can see here some of the small bowel loops filled with barium, as well as the terminal ileum and the ascending colon. And if you look carefully in this barium images, and you can see this very elongated filling defect inside the distal jejunum and the proximal ileum, which represents an ascaris wall. And this is just to test your look to the barium studies, and by the end of this talk I will present few cases, and I will ask you to answer the images. Then why we are talking about barium in these days? Because many patients do not like to start with the endoscope as a primary diagnostic imaging of the gastrointestinal tract. Also, barium can provide a roadmap, and it can help the endoscopist to see the site of the lesion and to predict the nature of the lesion in many cases. We have some obstacles with the endoscope, such as the endoscope cannot see outside the gastrointestinal tract. It cannot bypass the tight stricture, which can be passed by barium as it is fluid. And in many cases, it cannot determine the length, the exact length of the lesion, but with barium we can measure this. And sometimes it cannot reach some parts of the bowel. Then what's barium? Barium is a contrast material provided in powder, and it should be in this composite, which is barium sulfate, because any other component of barium, like barium chloride or any product other than barium sulfate, is considered toxic to the human body. Then barium is provided into powder, and we mix this powder with amount of water to get a liquefied material. Then the patient can swallow this contrast into the stomach like this, and he can have a nice image for the stomach as well as the duodenal bulb and the rest of the duodenal loop. Sometimes we cannot give the patient barium, and we give him a water-soluble contrast material whenever we are suspecting perforation of the gut or leakage in an anastomotic site. The gastrografin, if it has leaked into the peritoneal cavity, it will be absorbed rapidly from the site of the leak. Then how to examine the bowel or the gut by barium? The idea is to let the patient or take barium orally, or we inject the barium per rectum, and we image the part to be examined in different positions, aiming at obtaining images for the part which is empty of barium and filled with air, then a part which is filled with barium and empty from air. And this is what we call the double contrast examination, and this examination requires to see every part of the examined area, once filled with barium and once filled with air. Then to start evaluation of the gastrointestinal tract, we should agree about some of the terminologies. As the terminologies we agreed about in the chest, then we have the first one, which is the filling defect. What do we mean in the radiology report by a filling defect? We mean that there is something inside the lumen that does not make barium fill this area. Then we can see the shadow of the lesion, and the area of the lesion is not filled with barium. This is an esophagus. The upper part is filled, the lower part is filled, and this area which is occupied by the lesion is not filled with barium. Then you call this is the huge or an oval shaped filling defect inside the lumen. You may get also a filling defect from outside the lumen, something outside the lumen which is compressing the esophagus, for example, in this particular image. Then what do we mean by a stricture? Stricture means narrowing of the lumen. And narrowing of the lumen may be smooth and tapering like this, which is most likely a benign lesion. Or maybe like this, which has a proximal, what we call shouldering, and distal shouldering, and an annular narrowing in the middle. Written in the radiology books that this simulates the apple core, and you can imagine this like the apple, and someone has eaten part of it, and this means in our concepts that it should represent a malignant structure. Then the smooth appearance and the gradual tapering means that this is a benign lesion, and this abrupt shouldering proximal and distal to the lesion means that it is a malignant lesion. Then what do we mean by a diverticulum? A diverticulum is a saccular pouch connected to the bowel lumen, and if you give barium, this pouch should be filled with barium, like this diverticulum, and this one, and this one, and this very big one. Then what do we mean by ulcer? An ulcer is a crater which is filled with barium, and this appearance should be persistent in the images to say that this is an ulcer. If you look to the lesion emphase, you will see an area which is filled with barium with radiolucency around, representing the edematous mucosa. Then if you look it from the lateral aspect, you'll see a small projection beyond the wall of the stomach, and you say this is a small ulcer on the lesser curve, for example. Then we'll start to evaluate the different parts of the gastrointestinal tract based on these information. We'll start by the esophagus, and the esophagus is examined by barium swallow. Barium swallow is performed by introducing barium base to the patient, and the patient starts to swallow under a TV monitor. Then our aim is to image the esophagus while it is filled with barium, and once more while it is empty of barium. And you look here, this is the esophagus which is filled with barium. You see the caliber which is normal, and the contour which is regular. But you look here with the esophagus which is empty of barium, and you can look to the regular healthy mucosal pattern. And this is our aim. If we reach these two images, we can finish the examination. Then what are the lesions we expect in the esophagus? They are the terminologies we have just mentioned. We may see filling defect, we may see ulcer, we may see diverticuli, or we may see a stricture. And to adding for this configurational changes, which may result from displacement of the esophagus by extrinsic masses like mediastinal lesions, for example, and some motility disorders, or what we call the neuromuscular incoordination. And if you look here, this is the esophagus which is indented by a big mediastinal mass, and this is the esophagus which is patent, not indented, but you see the tertiary contractions in the esophagus, or what we call the non-propulsive waves. This is known as the corkscrew esophagus or tertiary esophageal contractions. Also, one of the motility disorders is achalasia of the cardia, and achalasia of the cardia means that there is a neuromuscular incoordination in the distal part of the esophagus, which is persistently narrowed, leading to proximal dilatation of the esophagus. The narrowing is smooth because this is a benign lesion, and the proximal esophagus is markedly dilated. This is a long-standing pathology. Then you can easily reach the diagnosis, and this is another case of esophageal achalasia, and you can see the narrowing of the distal part of the esophagus, proximal esophageal dilatation. Then you see a filling defect inside the esophagus, and filling defects may be due to benign or malignant lesions, and also we got filling defects secondary to varices, esophageal varices. But you should know that we cannot, by imaging, differentiate between benign and malignant filling defects, unless you have some of the aggressive characters. But we usually need the help of endoscope to take biopsy and to confirm the nature of the lesion. Then this is the classic appearance of esophageal varices, where you can see dilated, tortuous, worm-like structures in the wall of the esophagus, corresponding to these dilated veins in cases of portal hypertension. And if you perform a CT scan for these patients, you can see this is the esophagus with air inside, and you see the markedly dilated veins around. This is also a typical example of esophageal varices, and you can see the classic appearance. Then what about the strictures in the esophagus? The strictures may be benign, either due to corrosive or peptic ulceration, or may be malignant, secondary to malignant tumors of the esophagus. Then you look to the site of the stricture. If the stricture looks benign and it is in the upper part of the esophagus, this most likely represents a corrosive stricture. If it is of benign nature and is down near the gastroesophageal junction, then you may expect a reflux, esophagitis, and a peptic stricture. And this is a nice example of a peptic stricture in the distal part of the esophagus. Look at the smooth narrowing of the distal esophageal part and the regular contour with progressive tapering, as you can see. And this is a corrosive stricture in the upper part of the esophagus. Usually this happens near the level of the aortic arch, where the swallowed bolus stays for a while before going down through the esophagus after that. Then this is a typical appearance of a malignant stricture with proximal shouldering and distal shouldering, destroyed mucosa, irregular narrowing of the lumen, which represents malignancy. And this is a short stricture, malignant stricture in the distal part of the esophagus with small proximal shoulders and distal shoulders as well. Two different examples of esophageal malignancy, and this is another an example, and this is another example in the middle part of the esophagus. Then what do we mean by diverticulum? Diverticulum is an out pouch of the lumen which is filled with barium, and you have three types of esophageal diverticuli. The first one, which is very famous, is the Zinker's diverticulum, which is seen in the cervical esophagus, and you can see a pouch posterior to the course of the esophagus. Also, you may have a traction diverticulum in the middle part of the esophagus, which is usually secondary to inflammatory lymphadenitis in the mediastinum that has affected the esophageal wall, leading it to its weakness. Then you got this traction diverticulum. Then you see the third type of diverticuli in the esophagus, which is the epiphrenic diverticulum, and you can easily discriminate between this diverticulum and the hiatus hernia if you can see that the whole stomach is under the diaphragm, as well as the gastroesophageal junction is also under the diaphragm. This is the rarest type of esophageal diverticuli. Then you came to the stomach, and we usually examine the stomach aiming at the same idea, to get every part of the stomach once filled with barium, once empty of barium. Then you may turn the right side of the patient up, or let him in the supine position, or turn his left side up, or make the patient lie on his lateral aspect. No matter about what you do with the patient, what's important is to get these images. You see the fundus of the stomach filled with barium once and filled with air another time. The gastric body and the pyloric canal filled with barium, then empty of barium, and so on. You see here the duodenal cap, which is filled with air, and you see here the duodenal cap, which is filled with barium. This for contour abnormalities, and this for mucosal abnormalities. Then one of the most important values of the barium meal is to test for the gastroesophageal reflux, and the test was previously done in this wrong way, to elevate the patient leg and made the patient head downward, as you see. But nowadays we usually let the patient swallow barium, and we finish the examination, and before ending the examination, we ordered the patient to swallow a little amount of water while he is lying supine on table. Then you look to the barium under screen. While the patient is swallowing water, then you may got barium refluxing into the lower part of the esophagus. Then you confirm the diagnosis. And this is an easy way to test for reflux other than these old methods. Then the usual signs in the stomach: filling defects, ulcers, strictures, and diverticuli, and as well as configurational changes. Configurational changes involves the presence of hiatus hernia or valvulus or hypertrophic pyloric stenosis or compression of the stomach by masses in the gastric bed, particularly the pancreatic masses. And you see here, this is an example of a hiatal hernia, large hiatal hernia. You see here the fundus of the stomach, the gastroesophageal junction, all above the diaphragm. And this is another example of a hiatal hernia. This is the gastroesophageal junction, and you see both are above the diaphragmatic copula. You know that we have two types of hiatal hernia: the sliding one, where the gastroesophageal junction is above the diaphragm, and the rolling one, where the gastroesophageal junction may be below the diaphragm, but part of the stomach is herniating beside the esophagus. And this is relatively rare compared to this one, which is very common. Then to diagnose gastric volvulus, you just see that the greater curvature of the stomach is now upward, while the lesser curve is downward. In normal conditions, you see the greater curve to the left side of the patient and the lesser curve to the right side of the patient. Then, if you see the greater curve is up, then you will see the lesser curve down, and you see the duodenal cap facing down as well as the duodenal loop. Then you can easily diagnose the presence of gastric volvulus, which is commonly complicates the hiatal hernia. Then the hypertrophic pyloric stenosis may simulate achalasia of the cardium, and this is a neuromuscular incoordination of the pyloric muscle canal. Then of the pyloric canal muscles. And then you see that the muscles are hypertrophied, leaving a narrow track for the barium to pass through. And if you examine the stomach, you will find the stomach dilated because of the delayed emptying. Then you see the pyloric canal is tightly narrowed, and you can see it hardly or after half an hour, for example. Then you got a ossification of a normal duodenal cap and duodenal loop. And this is an example. This is the esophagus, the stomach, which is dilated, filled with barium, and you see the pyloric canal is narrowed. Everyone who is dealing with pediatric patients, he can know very much that if you give the child some barium, you will find it immediately in the jejunal loop and in the ileum as well. Then the filling defects in the stomach are either benign or malignant or abnormal food. And you know that the mentally retarded people or some of the people who may try suicide, for example, may swallow abnormal things into the stomach, and you can differentiate these abnormalities from benign and malignant lesion by putting the patient into different positions. Then you can see that this filling defect is mobile inside the stomach, while the benign or malignant lesions are arising from the gastric wall. They are not mobile by changing the patient position. Then can you predict which foreign body has been swallowed by this patient? Sorry? Bottle of A.
Some kind of tablet.
Tablet. It's a big for tablet. Giant tablet. Mobile. Yes, good idea. But you can see some of the machines inside the mobile. Okay. This is the swallowed thing. And can you predict how many of these inside his stomach? How many? How many pieces inside the stomach? Three. Where? This is one. Where the two? Here? No? Can you see this one? You see it from this side. and the rest of this is in the fundus, lying down in the fundus. Okay, then the filling defects of the stomach may be benign or malignant, as I have said, and usually the malignant lesions, particularly the leiomyosarcoma, tend to grow outside the stomach, not inside the gastric lumen. Like this example, and you see some irregularity of the wall of the stomach, and you got an impression of a big mess here. And if you would like to see this mess, you just look to the CT scan. Then you can see this is the liver, this is the spleen, and this is the stomach filled with contrast material, and this is the whole tumor which lies outside the stomach. But sometimes you can see the lesion which is inside the gastric lumen, but you can see that barium cannot pass in this area, denoting that this lesion is arising from the gastric wall and it is not a foreign body. And you can confirm this by CT scan. This is the stomach, and you can see the filling defect inside the stomach. This is the liver, and this is the spleen. Gastric polyps also produce filling defects inside the stomach, and we usually agree about the fact that the polyp which has a pedicle is usually benign, and the polyp which is sessile is usually malignant. But this is not true, since it is impossible, it is written in our books, it is impossible to differentiate benign from malignant polyps by barium. We need always the help of endoscope to take a biopsy and to confirm the diagnosis. We're all familiar with this imaging of gastric carcinoma. You can compare this and these images of gastric cancer by this normal appearance of the stomach. And here you see the fundus of the stomach, the greater curve, the lesser curve, the duodenal cap. But here you can see this very big annular restriction in the gastric body with marked irregularity and mucosal destruction. Also look for this stomach which is not distensible, with rigid outline and the irregularity of its wall. Once the patient takes barium, barium passes immediately through the stomach into the duodenum and the jejunum. And you know that this is known as the Leionitis plastica, or the scarus carcinoma of the stomach. And this is the drawing of the scarus carcinoma of the stomach, an example with barium, another example with barium, and this is the normal gastric appearance by barium. Then if you see an appearance like this in the barium study, you may confirm the presence of a pathology here and there by CT scan. You see this is the stomach, this is the contrast inside the stomach, but you see the tumor affecting the wall of the stomach here and there, markedly encroaching on the lumen in this particular area. Considering gastric ulcers may be benign or may be malignant. But the criteria for malignant ulcer are: the ulcer is usually, the malignant ulcer is usually present in the lesser curve, it is usually larger than 2 cm in diameter, and if you look to the mucosa, you find the mucosa stops away from the ulcer edge. Look at here the benign ulcer, these are the mucosal folds reaching the edge of the ulcer. But this ulcer is a malignant one, and look, the mucosa stops away from the edge of the ulcer because all this distance is infiltrated by the tumor. Then if the mucosa is away, then you know that this is a malignant ulcer. If the mucosa reaches the edge, then you know that this is a benign ulcer. Then you can say safely this is a big malignant ulcer in the greater curve of the stomach, and you see the mucosa stops away from the edge and the ulcer is bigger than 2 cm in diameter. Also, you can see a lesser curve ulcer which is also malignant, and you see that the mucosa is stopping away from the ulcer edge. Then you shift for the duodenum, and the lesions in the duodenal cap are few, and they are only confined to the ulcers and divertically. If you see the normal appearance of the duodenal cap is triangular in shape, smooth in outline. If you perform a barium study and you found this persistent area filled with barium, then you know that here there is an ulcer. And in such a condition, you can call this is acute duodenal ulcer. Since a chronic duodenal ulcer usually are associated with fibrosis and results in marked deformity of the duodenal cap. the duodenal cap is no more triangle, then you see this deformity, you diagnose chronic duodenal ulceration. If you see this persistent area of barium, then you call it acute duodenal ulceration. Then if you see this duodenal cap which looks normal, and after emptying barium you can identify 2 areas of persistent filling with barium, diagnostic of 2 acute duodenal ulcers. And duodenal diverticuli are also common, and they are symptomless unless they are near to the ampulla of water, and they are common in the second part of the duodenum. And if they disturb the biliary drainage through disturbance of the ampulla of water, the patient may get biliary complications. Then you look to the small intestine, and we examine the small intestine by this type of examination, which is known as barium meal follow-through. We give the patient a barium meal, which is about 30 milliliter of fluid barium, and we follow this barium every few minutes. And we got the first image after barium intake. A few minutes later we get another image, and then another image, aiming at following the barium through the intestine until we reach the terminal ileum and the ascending cecum and the ascending colon. Then we finish our examination. And this is the first image. You see the stomach filled with barium, and you got the normal appearance of the jejunum. Then after that you get more opacification of the bowel, and later on the stomach is empty, the jejunum is also starting to empty, the ileum is filled, and the colon is starting to appear. Then you finish the examination by this. What are the abnormalities in the small bowel? The same: filling defects, ulcerations, strictures, diverticuli, and configurational changes. And the configurational changes here is just in the mild rotation of the bowel. And you know that the jejunum should be in the left upper quadrant, and in this patient the jejunum is in the right side of the midline. Then you can diagnose malrotation of the bowel. In this patient, the colon is to the left of the patient and the small bowel is to the right. Then you can easily diagnose bowel malrotation. Then there is a single disease that can produce a lot of changes inside in the small bowel, which is the Crohn's disease. And the Crohn's disease can produce filling defects, can produce ulcers, can produce strictures. And the Crohn's disease, as you all know, is a granulomatous disease, and its cause is unknown and is usually affecting the terminal ileum, resulting in luminal narrowing and mural ulcerations, strictures, fistulae, and perforations, as we will see. Then the most common appearance of Crohn's disease in the small bowel is affection of the terminal ileum. And the terminal ileum may appear markedly narrowed, like this appearance, and you can compare the pathologic terminal ileum by the normal terminal ileum. You see the mucosa, the caliber, the regular outline, but here you see marked luminal narrowing, no mucosal appearance, destruction of the mucosa, and this usually the appearance of Crohn's disease. But also you may got what we call cobblestone appearance in the terminal ileum, which is also one of the classic appearance of Crohn's disease in the small bowel. You get this, which is almost similar to the cobblestones on the road. Then this is also one of the famous appearances in the Crohn's disease. This is the terminal ileum, and this is the ascending colon. One of the important features of Crohn's disease is known as the skip lesions. And that's to say the Crohn's disease affects part of the small bowel, then part is healthy, and then it starts to affect another part, and so on. And this is another example of escape lesions in Crohn's disease. You see a stricture here, and a segment which is normal, and another stricture here. This is also one of the common features of Crohn's disease. You have seen this cobblestone appearance compared with the normal mucosal pattern. Then Crohn's disease can affect any part of the gastrointestinal tract, but the affection of the esophagus is considered very rare, and the most common site is the terminal ileum, as I have said. Crohn's disease may lead to perforations. It starts first by ulcers, then the ulcers penetrate the intestinal wall, then they perforate either in the peritoneal cavity or in the adjacent bowel, like perforation of the small bowel into the small bowel, or a small bowel into the colon, or a small bowel into the renal bladder. And these are frequent findings in Crohn's disease, and this is an example. You can see multiple loops are connected to each other through fistulous communications. Also, Crohn's disease may perforate through the skin to get a cutaneous fistula, and this is also one of the manifestations. Sometimes you may see a filling defect inside the small bowel, and this is a relatively uncommon situation. But if you see that, you may confirm this finding by CT, and here you can see a mass, and you can see through the mass a bowel which is running inside the mass. Then you know that this mass should arise from the bowel. And if you know that, if you can predict that this is a small bowel, then this mass is most likely a lymphoma. But if this bowel is the colon, then this mass is most likely colonic carcinoma. And lymphoma in the bowel usually produce masses in between the bowel lobes, and they result in marked separation of the bowel loops like this. But normally, you should see the bowel loops are intimately related to each other. And you should confirm the possibility of lymphoma here by doing CT. Then you see the bowel loops normally filled with contrast and are separated by multiple intra-abdominal masses of lymphomatous nature. And the last issue of the small bowel is diverticuli, and diverticuli are rare in the small bowel compared to the duodenum. Diverticuli in the duodenum are common, but in the small intestine are relatively rare. And if you came lastly to the colon, and the colon is examined by the barium enema. And we do not anymore use this single contrast barium study, but we use the double contrast. We introduce barium, some barium, then we introduce air. And we fill the colon with air and barium, and we start the diagnosis. The first is configurational changes, and you know that malrotation is also one of the common causes in the colon. And here you can see the cecum, instead of being here, is now in the left lumbar region. And this is malrotation of the cecum. Diverticular disease of the colon is the most common site for diverticuli in the whole gut is the colon. And you can see multiple diverticular outpouching, usually present in the descending colon and the sigmoid colon. This is the most common area to be involved by diverticular disease. And these are two different examples of diverticular disease of the colon, and you can see diverticuli. Also, you can see here diverticuli. Diverticuli have many complications, especially perforation and malignant change. Once the diverticulum is ruptured, it may perforate into the peritoneum or may perforate into the adjacent organ. And very commonly, a diverticuli may perforate into the peritoneum, leading to a pericolic small abscess, and this abscess may perforate into the urinary bladder, resulting in air fluid level inside the urinary bladder. And this is just a normal example of the urinary bladder, which is filled with urine and no air inside the urinary bladder. You see here the urinary bladder with bowel loops adjacent to it. But in this particular case, you see the inflamed colon, the abscess in the pericolic area, and air inside the urinary bladder. Then ulcerations are usually produced in the colon by two major diseases. Commonly by ulcerative colitis, less commonly by Crohn's disease. And ulcerative colitis, you know that this disease usually affects mainly the descending colon, resulting in marked loss of haustral pattern and leaving the colon featureless. There is no haustra and the lumen is markedly narrow. And if you look here, this is the normal colon with normal haustration, but here you see that the colon is here. The colon is filled with air, but you cannot see any haustra. The colon wall is straight, and if you look carefully inside the colon, you may see minute ulcers all through the colonic area. Then loss of haustra is one of the major diagnostic features of ulcerative colitis, and if you can see the minute ulcerations, you can reach the diagnosis very easily. Many ulcers will result in granular appearance of the colon, and this is what we call fine mucosal granularity. And also you may get ulcers outside the colonic margin, and in such a case we call it the tram line or double tracking appearance. This is an uncommon finding, and this is a common finding in the barium enum. At the end of the disease, you may got this appearance of the colon. The colon is like bulb stem appearance, no hostra at all. The lumen is markedly narrowed, and you may see multiple filling defects, what we call pseudobulbosis. And these are not true polyps, they are hypertrophied normal mucosa compensating the function of the damaged ulcerated mucosa. Then Crohn's disease in the colon may result in a typical appearance which is known as aphthoid ulcer. Aphthoid ulcer is a small ulcer which is surrounded by a halo of edema, and you can see here many ulcerations in this segment, where each ulcer having the typical criteria: an ulcer crater filled with barium surrounded by mucosal edema, and this halo of radiolucency represents mucosal edema. Also, Crohn's disease may result in a stricture of the colon, but any stricture of the colon should be diagnosed as malignant until proved otherwise. We cannot diagnose for the first time a stricture in the colon as Crohn's disease. We should diagnose these strictures as cancer until proved otherwise. Then polyps in the colon, like polyps anywhere, the pedunculated polyps are usually of benign nature, and the sessile polyps are usually of malignant type. Then this is an example of a benign polyp which is pedunculated, a smooth outline, and this is an example of a malignant polyp. And the polyp is sessile because you cannot see barium passing at this edge, and the surface of the polyp is irregular. Then you are dealing with a malignant polyp in the colon. Then you know what, this disease which is known as familial bulbosis, where you got the colon, the whole colon is studded by polyps, and the polyps may be minute, may be large, and you see so many polyps inside the colon. And you also know that this disease has 100% incidence of malignancy if not treated, and this is the familial bulbosis of the colon that has developed malignant stricture with proximal shouldering, as you can see. Then you came to the last issue, which is the colonic carcinoma, and the carcinoma is usually of the adenocarcinoma type, may present as a polyp or ulcer or a stricture. But the stricture is the most common appearance of colonic cancer. Then this is an appearance of polypoid lesion. You see a filling defect here. You cannot see its base, meaning that it is sessile. Also, you see this cecum with a big filling defect in this area, representing a cecal carcinoma. The stricture in the colon, this is the most common appearance of malignant colonic lesion, and you see the drawing representing the tumor infiltrating the colonic wall, leaving in our lumen. And this is exactly represented in barium. You see the proximal shoulders, the distal shoulders, the narrow tract for barium to pass, and this area is occupied by the tumor, and this area is also occupied by the tumor. And this is another example of a stricture in the colon, which represents malignant stricture. Then if you got a stricture in the colon, you may have three possibilities. The first and the most common one is carcinoma, but less common is lymphoma, and least common is Crohn's disease. In such conditions, you should have an endoscope to look at these strictures and take a biopsy to confirm the diagnosis you are dealing with. Then we came lastly to the quizzes, and you are invited to answer these questions, and if radiologists are there, they are not invited for these quizzes. Okay? Go ahead. What do you think about this area, and what is the organ to be examined here? The esophagus. Then what is the lesion? Okay, this is the lesion. What do you think? Yes? Yes, this is an esophageal diverticulum. Diverticulum is a pouch filled with barium. Okay. What is the organ? A stomach. What is the lesion? Yes, this is an ulcer, and you see here the ulcer is evident, and here you can see the ulcer is on the lesser curve, and it is larger than 2 centimeters. This is a malignant ulcer. Okay, which part? Colon, rectum particularly. You see the nozzle of the barium enema. Then what is the diagnosis? A stricture, and what's the possibility? Malignant. Yes, malignant is the first possibility of any stricture in the colon until proved otherwise. What is the organ? A stomach. What is the lesion? This is the lesion. What do you think? Malignant ulcers do not usually occur in the duodenal bulb. But most of the duodenal bulb ulcerations are of the benign type. This is benign peptic ulceration, acute peptic ulceration in the duodenal bulb. Okay, what is the organ? Stomach. What is the diagnosis? Huh? Yes. Anyone who said this is hernia? Yes, okay. This is a sliding esophageal hiatus hernia. You see part of the stomach is above the diaphragm. This is the diaphragm, and this is the gastroesophageal junction, which is well above the diaphragm. This is the hiatus hernia. What do you think about that? Forget about the chest. What do you think in this part? Sorry? This is stomach? Is esophagus. Okay, this is the rest of the image. What do you think? Here is the stomach. And you see the stomach is down. Oh. Yeah, this is a chalasia of the cardia, and this is the narrowing of the distal part of the stomach, of the esophagus, and this is the whole esophagus, which is markedly dilated, containing food and buried. What do you think about that? The stomach bottom. Sorry? Bilateral? Hypertrophic pyloric stenosis, yes? This is the stomach, which is dilated, the pyloric canal is narrowed, and the duodenal cap is opacified. This is hypertrophic pyloric stenosis. What do you think about that? Filling defect where? In the cecum. What do you think about? Cancer. Yes, this is a cecal malignancy. Is there any lesion in the colon other than malignancy? Yes, there are multiple colonic diverticuli. And this is a cecal carcinoma and colonic diverticuli. Then what do you think about that? Which organ is this one? Sorry? This is colon, this is the lung, and this is the diaphragm. Then this is the esophagus. What is this lesion in the esophagus? Yes, this is esophageal varices. Okay, which part of the bowel is this one? This is the stomach and the small bowel and part of the colon. This is barium meal follow through. Can you see the pathology? Yeah? Yes, where? Restriction where? Yes, in the terminal ileum. This part of the terminal ileum is not regular. Partly is narrowed, dilated, narrowed. Then what is the diagnosis? Crohn's disease. Good. Okay. Which part? Esophagus. What is the diagnosis? Corrosive stricture of the esophagus. Very good. Okay. What is that? Colon, barium enema. What is the diagnosis? Ulcerative colitis. There is loss of ostra in the colon, and you got minute ulcers all through the colon. Okay. What do you think? Colon. What's the diagnosis? Diverticular disease of the colon. Yes, this is true. What's part? Stomach. Yes, this is the stomach which is filled with air. This is the duodenal cap and this is the duodenal loop. What is the diagnosis? This is the most difficult one. No, this is regular mucus. Cobblestone is like البلاط اللي في الشارع. Radiologists also can answer. Where? Here? Here? This is normal. Okay, this is normal duodenal cap and loop, and this that's why I said it's very difficult. Okay, what do you think about that? Yes, this is ulcerative colitis, colon ulcerative colitis. Okay, what do you think about that? Yes, cancer esophagus. And you see, this is barium swallow. This area is irregular, proximal shouldering, distal shouldering, cancer esophagus. What do you think about that? Cancer? Which part? Colon. Yes. And this is the ascending colon. You see the apple core appearance, proximal shouldering, distal shouldering, denoting malignant stricture, colonic carcinoma. What do you think about that? Achalasia, yes. This is the esophagus which is markedly dilated and you see a smooth tapering edge. Okay. What do you think about that? The stomach. And the stomach here is involved by what? Tumor, yes. This is gastric carcinoma. When you see the rigid appearance of the stomach, the markedly narrowed gastric lumen, and you see by CT scan the marked thickening of the gastric wall encroaching on the gastric lumen. This is gastric cancer. What do you think about that? No? If you remember my first slide, you can answer easily. Yes. This is a scarce wall, and you can look carefully here inside the small bowel, and you can see this filling defect which represents the scarce wall. Then what do you think about that? What is this examination? This is very minimal, and you see this is the colon, and this is the terminal ileum filled by reflux. Then you see. Do you see the site of the lesion? Down to the left or to the right? يعني كده ولا كده؟ كده. أيوة ده يعني. Okay. What do you think about the stricture? And stricture in the colon is straightforward. This is malignancy until proved otherwise. The stricture of the colon should be considered as malignancy until proved otherwise. Thank you very much. Then you go to the break and we'll continue after 15 minutes. Okay, thank you.